Good morning. Are we ready for day 2? Everybody having fun? Good. Just a couple of items to note this morning. Our pop-up shop will be open until 2 o'clock today, so make sure you get over there and make your purchases before 2. And we've also added another item. The turtle logo was designed by our liaison, Julie Bell's daughter. And we really just thought it was so spectacular, and we've gotten so many requests and interest that we printed a bunch of copies on photo paper, so they're available at the pop-up shop as well. So we will do the drawing for the raffle tonight at the closing fiesta party. Let's see, lunch today, if regional directors, liaisons, and points of contact would grab their box lunch and meet in Regency, it would be a nice time for them to gather and exchange ideas. Our photo booth by Griffles will be open through the closing ceremony tonight, so please make sure you record your memories with your new family members. I also wanted to let you know that Dwayne Hooks, who has his PhD in nursing, has doing some study on nursing guidelines for moderate to severe GBS. He published a paper in our spring communicator, and he is at our foundation table across the way, and he's interested in interviewing more patients. So if you have an interest in helping him continue his study, please see him at the foundation table. And last but not least, next week you will be receiving an email with us asking for your feedback on the symposium. Each year, every other year, we try to bring you the best symposium for what you want and what your needs are. So please take time to fill out that survey and email it back to us. And everybody that participates in the survey will be entered in a drawing for a fabulous foundation item. And now I would like to introduce Dr. David Cornblath, who comes to us from Johns Hopkins. He's a member of our Global Medical Advisory Board, as well as our Board of Directors. And he is going to speak to us about Zika.
Okay. Great. So anyway, it's early. I'm glad to see that my 2 talks didn't make everybody stay up in their room. So I'm the chosen speaker about this, and you'll see why. It's not like I'm a content expert about Zika. I know a bit about GBS, but I had the opportunity to go with some people from Hopkins, particularly Carlos Pardo, down to Colombia, South America in March of this year, and see cases, talk to the doctors down there, and I'll tell you a little bit about some of that work. So let's just see, yeah, the usual, right. There's our advertisement again, the GBS 100 book, again, freely downloadable on either the GBS-CIDP website or the PNS website. You can find it easy. So if you look at bullet point 4, that's the most critical thing here. Bullet point 4 tells you that all these Zika slides I stole for free from the CDC. Because, like I said, I didn't have any. So I'm just going to run through these and then tell you a little bit about, what we had. But I think you'd have to be almost brain dead in the last 6 months to not know what I'm going to tell you about Zika, because it's been in the news, gosh, 100 times a day. And particularly the association with GBS, which is extremely interesting. So everybody knows that, you get bit by this mosquito, and if the mosquito has the virus in it, then you're going to get the virus. Turns out that most of the people who get infected don't have any symptoms. And this makes it a little bit difficult, as the people from the CDC and other places will tell you, to sort of do proper epidemiology, because so many people are asymptomatic, which is why you saw the screening for blood, because anybody who's ever given blood, they ask you if you've been sick recently or you're sick today, but it turns out, of course, you can have Zika in your blood but not be sick. So it's a particular problem, and everybody, of course, knows about, the sort of secondary effects on the nervous system, frankly, the central and the peripheral nervous system, depending on, who and where you are. So You know, Zika was found in Africa, in the Zika forest, so-called, and Hugh Willison, who's not here, but a valued member of our scientific community, is from Glasgow, and he always reminds me to say that Zika virus was discovered by a University of Glasgow scientist who was working in the forest. And that's the sort of circles in the inset, and that's where it was until it jumped over, and then you can see its sort of movement, and then, of course, everybody knows its explosive movement this year, racing up from sort of the bottom of South America up through into Central America, now into the sort of southern parts of North America of the United States. So how do you get it? Well, most people are going to get it through bullet point 1, that is a mosquito bite, but we now know you can get it, that women can pass it to their fetus, and that's presumably what leads to not just the fetal malformations, but of more concern to my colleagues in pediatric neurology is what are going to be the longer, much more subtle effects on the brain of kids who are born to mothers who have Zika, who aren't obviously microcephalic. This is just being explored, but the people who think about this are extremely nervous because subtle defects aren't going to be picked up by the infamous ultrasounds or MRIs or any of this other stuff. You can have sex with somebody who has it, and probably you can get it through one of these other mechanisms because it remains in fluid for a long time. And there are now a number of published studies that suggest that the virus can be in your urine for weeks to months. It can be in semen for weeks to probably a couple of months. So these are the common symptoms, that is the top ones, but again, most people are asymptomatic. It leads to a sort of a mild viral syndrome that, you know, you can't tell much different from several of the others. Now, the colleagues of mine in South America, who are much more used to than any of us in this room, seeing chikungunya, dengue, and now Zika, can tell them apart because different ones have a different characteristic feature. And, you know, they like joint pain and particularly conjunctivitis to help them tell that somebody has Zika and not one of these other two. Muscle pain and headache are very uncommon. So who can get it? Well, anybody can get it as long as you go down there. I mean, I went down there. Presumably I didn't get it, I don't know, but because I didn't get tested, frankly. But, you know, I went down there, and if you go down there now, it's possible for you to get it. The epidemics themselves are predominantly over in South America, and nobody's quite sure. Maybe our friends from the CDC can help us tell what they think might happen next year, but this sort of peak and trough, that's already passing through all these countries, and they're just not seeing cases again. Good. So this has obviously been, you know, headline news all the time, and it's thought really that the virus attacks the central nervous system, and that's the great concern. And there are beginning to be studies. There was an early one showing that the virus can attack neurons in cell cultures. So somebody said, well, at least that seems like a probable mechanism. It's not like they can't. That doesn't mean that's the mechanism in humans, but that's likely to be the mechanism based on emerging data from autopsies of infants. And so it's really a big problem. As everybody knows, the women who are pregnant in these areas are somewhat petrified. They stay inside, they don't go out, they spray themselves up, and they do all the things that I'm going to show you in another slide about what to do. So this is the best slide to date of data. It's hard to see, but each one of these, and I'll try and point it out, each one of these little graphs is from a particular country in South America. And the big peaks are Zika, that is the green, is the sort of epidemic in Zika, the number of cases over time, and the yellow below are the number of GBS cases. This is a publication recently in the New England Journal. And at the bottom is sort of all of this data compiled, that is compressed together. And so you see this peak of Zika, and below it a peak of GBS. Now, one of the things I want to point out that's interesting, and I'm going to tell you again in a second because it's so very interesting, is if you look at those peaks, right, we normally think about GBS as post-infectious, right? And we've heard about this for a couple of days now. That is, you get your infection goes away, right? And then you get your GBS. That's what we call in our world post-infectious. infection after the infection is over. And if you look carefully at this, it looks like it may not be exactly post-infectious, but may be what's called para-infectious. That is, you're infected with Zika, you have the symptoms of Zika, and then you get GBS. So there's not this sort of, if you will, window of opportunity or window in which we, as a scientist, think this immune reaction is going on, but rather something hyperacute and different. And in fact, this is the same data from Colombia, and you see the same sort of thing. There's the Zika in the gray and the GBS cases in the red. And you can see, look at they're sort of actually offset. If it was classically post-infectious, you would expect that red to be over to the right, just as, for example, yesterday, Peter D'Onofrio showed you this classic picture now of GBS following the swine flu vaccine. Remember, the swine flu vaccine started here, and then you see the peak after it, right? And he said it goes out about 6 weeks, and you see it coming up and down. Here you're seeing a slightly different thing. And so, I had the opportunity, as I said, to go down with Carlos Pardo, who had put together a working group that's entitled KNEES, of a number of Colombian physicians, hospitals, to study the nervous system effects, both GBS and others, of Zika. And so we went down there and had an opportunity to hear the doctors tell us about the cases that they've seen, the extraordinary amount of increased incidence, and in particular this time lag. And so these are the sort of points that we got that are from it. That is, that our study, like now 2 other published studies, and the study from French Polynesia of a year ago, show that Zika and GBS are very tightly linked. That came first from a published study from French Polynesia. Again, Hugh Willison, whose name I mentioned, was on that study, and now there are 2 other papers printed, another one from Colombia, and one we'll hear about. It's already published from Puerto Rico about this tight link. What was interesting in ours was that almost half the people had their GBS onset while they were still sick with Zika. So it suggests that maybe the mechanism is very different or might be different in those cases versus the classic post-infectious polyneuropathy. In our cases, most of them have the so-called demyelinating form of disease, not the so-called axonal forms. And although it's been published that there are axonal forms, those publications are probably incorrect based on review of the data. And as I told you, urine seems to be a long thing. So we know how Zika is diagnosed, right? You get the right history, you get the right symptoms, and then you need to do confirmatory testing. And this is the CDC recommendation about women who are pregnant should be tested at every visit. There's no treatment for it, right? You just get over it, but you treat the symptoms. What do? You try to protect yourself. If you got it, you don't go around and have sex with other people, et cetera, et cetera. You got to wait because you don't want to pass it on. How do you protect yourself? Well, these are the sort of things that everybody knows. If you don't want to get mosquito bites, right? None of these are brand new. None of these are particularly novel. You keep your mosquitoes outside, right? You put up screens. You don't have your windows open. You wear clothing that covers you up. You wear DEET, right? You make sure your kids are protected with DEET. You make sure everybody else is protected. You use a condom if you're having sex. And you go do your homework so that, when my daughter says to me, geez, I'm going to go down to visit Disney World, I go, well, maybe it's actually not such a good idea because, you're in the age in which you might get pregnant. Maybe you ought to think about postponing your trip. So travel wisely if you're in the age groups that are worried about this stuff. Do your homework. So the CDC website, if anybody really wants to be updated, it's really fantastic. The stuff is written at a level that any person can understand. You can get stuff that's a bit more scientific, but boy, oh boy, do they really do a good job on their website. So here's the sort of stuff that makes it interesting from our standpoint and why quite a number of us were lobbying very hard, both the CDC and the NINDS, starting in sort of January of this year. Unfortunately, I can report to you we didn't get anywhere with either of those federal agencies. But it's the close linkage between GBS and Zika that makes us so excited and interested in this. And other than the link between Campylobacter, which you've all heard about, we don't have anything that's this tightly linked. And if, again, you think broadly, much of what we've told you about what we know about GBS and stuff actually comes from studies of Campylobacter, right? So we had hoped that we could get projects online with Zika so that we could collect the kind of stuff I'm going to show you in a minute and really begin to understand it the way that we now understand GBS because of the linkage with Campylobacter. So the epidemiology was right, find Zika, GBS follows. How it leads to it, that's what nobody knows. We don't know if the treatment should be different. We don't know why it's para-infectious rather than post-infectious, and we don't actually know what the mechanism is, whether it is in fact still immune-mediated or whether it's some other much more direct way to do it. And so what we had hoped we would do would be to convince agencies that are doing the plain old epidemiology to simply follow the IGOS protocol. Not really difficult, just go and importantly collect the specimens and the clinical data so that it could be archived away and we could have it to store. Now we do have that from our work in Columbia, and that's going to be shared around with a number of the GBS investigators, and hopefully we'll hear that in fact the CDC has collected material in a systematic way and is willing to share it with GBS researchers, not just for the epidemiology of Zika. So that's it. That's all I have to say. I hope I'm good. I spoke for 15 or 20 minutes, and I'm going to get followed by a real expert.
Thank you, Dr. Cornblath. And now it is my pleasure to introduce Emilio Dirlikov of the CDC. He is temporarily located in Puerto Rico. As you may have heard, there's a real outbreak of Zika and GBS following Zika in Puerto Rico. So we are actually hosting a chapter meeting in a couple of weeks with our liaison in Puerto Rico. And Emilio has been a great support and really wants to partner with us. So he is going to give us an update on Zika in Puerto Rico. Emilio.
Buenos días y gracias por la oportunidad de estar con todos ustedes para hablar sobre el síndrome de Guillain-Barre en estos tiempos de Zika. That will be the only bit of Spanish for this presentation, but thank you for having me this morning. So as we know, Guillain-Barre is an autoimmune disorder characterized by damage to the peripheral nerves and sometimes nerve roots. And as Dr. Cornblath has mentioned and several other experts, GBS has been associated to a variety of different infectious agents and also a number of vaccines. So these include bacteria such as Campylobacter, Shigella, leptospirosis, and viruses such as HIV, influenza, the virus as well as the vaccine, and dengue and chikungunya viruses. And these are viruses that are transmitted mostly by Aedes aegypti mosquitoes. Those are the same mosquitoes that transmit Zika virus. And now we're talking about Zika virus, and this is why I'm here today, to understand a little bit more about your experience and how we can support our Zika virus-associated GBS patients in Puerto Rico. So it's important to remember that GBS is still a very rare condition. Globally, GBS incidence, or the number of cases that present per year, is estimated between 1 and 2 cases per 100,000 population. And this, of course, varies by geographic location as well as by age group. So in places like Finland, where they don't have a lot of bacterial or viral infections, we have a lower incidence of GBS than in places in the tropics, like the island of Curacao in the Caribbean, other places where you might have a nice tropical vacation, but you're more exposed to bacteria and viruses that are endemic there. And we also see that people that are older ages, 50 and above, 50, 55 and above, we have a higher incidence of GBS. In Puerto Rico, a preliminary study that we conducted at the beginning of the year to estimate the incidence, we estimated that we have 1.7 cases of Guillain-Barre per 100,000 population. So right in between that 1 to 2 cases per 100,000 population. And so given that we have 3.5 million residents of the island of Puerto Rico, we estimate that that's about 60 cases per year, or about 5 cases each month if we assume that these cases are distributed evenly throughout time. Of course, why do we want to know what the baseline incidence is? We want to make sure that we know what is normal levels, so any increase in normal levels, we can detect that, right? But we first have to define what is our background incidence on the island. Why are we concerned about Guillain-Barre in these times? Why is this a public health concern? Well, countries that have been affected by the Zika virus have concurrently reported an increased number of the cases of Guillain-Barre. And these are a number of different countries that have been affected by Zika in Southern and Latin America, as well as the Caribbean. And especially that study that was just published in the New England Journal points to 7 of the countries, including Brazil, Colombia, and our neighbors to the west, the Dominican Republic. During a very well-documented outbreak of Zika virus in French Polynesia between October 2013 and April 2014, 42 cases of GBS were identified, all of which had evidence of Zika virus infection. And this is over a course of 6-month period. Now, normally, just to put this into perspective, normally, French Polynesia was only identifying 3 to 10 cases of Guillain-Barre per year. So you can imagine 3 to 10 cases to a jump within 6 months to 42 cases is something exceptional. It's something that us as public health workers were very concerned about figuring out why that jump was happening. So in Puerto Rico, when we identified local transmission of Zika virus at the end of 2015, we wanted to make sure that we were doing something to better understand Guillain-Barre patients that might be presenting in that year. We didn't want to assume that we would have an increase, but of course, given the evidence from other countries, we wanted to make sure we had a system in place to identify the cases that were presenting that year. And indeed, we were fairly fortunate that within the first 30 cases of Zika virus identified in Puerto Rico, one of those people was somebody who was diagnosed with Guillain-Barre in early January. The results came back on the 2nd of February. So very early on, we had this evidence that it could happen in Puerto Rico as well. So with the assistance of CDC, the Puerto Rico Department of Health implemented a novel GBS passive surveillance system to identify new cases of suspected GBS, as well as other neurologic conditions, as early data was also suggesting that Zika might be associated to other neurologic conditions like encephalitis or myelitis. So we say passive because this really relies on clinical suspicion of Guillain-Barre. We're not in every hospital. We have limited resources to respond to the epidemic. So we really rely on this clinical suspicion of GBS for providers to report to us. And in order to do so, healthcare providers from across the country can submit a case report form. And this allows us to gather some basic information about the patient to have in our database. And furthermore, along with this case report form, providers can submit a variety of different samples, including serum and now whole blood, which we're finding is a little bit more sensitive for detecting Zika virus, even in the long term. Urine, which also seems to have a longer, the virus seems to be replicating or is present in urine for longer periods of time. Any CSF that is left over after a lumbar puncture, we're not suggesting that the patient get a lumbar puncture just because of a suspicion necessarily, but if it's part of the clinical practice already, if they can save a little bit so we can see if the virus is replicating there as well as saliva. So we're really trying to collect as many samples so that we can better understand how the virus is comporting itself within the body. And this is an example of our case report form, which is available on our website both in English and in Spanish. So any jurisdiction that you might be affiliated with that is interested in reporting cases or setting up a surveillance system, we have a lot of the tools available there too. So in addition to kind of the basic demographic data that we're collecting, sex, age, location of residence, so we can relate those GBS patients with other known Zika virus infections, as well as provider information so we can directly contact that provider as soon as possible when we have a Zika virus result. I personally call each provider as soon as we have a result that is positive for Zika virus in order for them to raise their clinical suspicion and be a little bit more involved in the process. In addition to that, we're also using this case report tool as an outreach tool. So we have a section for clinical presentation of neurologic symptoms. Did the patient have bilateral flaccid weakness? Did they have a loss of deep tendon reflexes? Many of these clinicians in Puerto Rico don't see a lot of Guillain-Barre patients. There's a limited amount of neurologists on the island. So we want to make sure at every step, when they check that box, it's a reminder that they should be looking for these specific symptoms when they have a clinical suspicion of Guillain-Barre. We're also collecting data on this initial form on antecedent illness, this preceding symptoms that might give us a clue as to what was the pathogen that this patient had that triggered the Guillain-Barre. So did the person have a rash, conjunctivitis, any arthralgias that might be indicative of infection with Zika virus, or diarrheas that might be indicative of a gastrointestinal pathogen? We've also developed a number of other outreach tools for our providers. We have posters that help them outline how they should be submitting samples to us with our phone number, basic signs. And we've been doing a lot of community events as well. One of the partnerships that we've developed on the island is with the American Association of Retired Persons. So precisely this population that's over 50 years of age, to really empower them to go back to their constituents and say, this is the message. You need to protect yourself against Zika virus, but also be aware of these initial symptoms so you can go to a reference hospital where you're more likely to get adequate treatment. And all these outreach materials are available online, mostly in Spanish and in English. One of the biggest things that we've been trying to do in order to get our clinician buy-in is a bi-weekly report, and sometimes we put it out every week. And this is so that people are able to be actualized in the moment on how Zika virus and Guillain-Barre are presenting themselves in this year. So, especially with such a rare disorder, we want to make sure that we're collecting statistics that promote people to report and people to raise that clinical suspicion. If you're in a small hospital in rural Puerto Rico, we've had one hospital report just one case, right? So they might not think that there's anything abnormal necessarily, but when you put the data together, it tells a story of an increased number of Guillain-Barre patients around the island. So in this year, we've identified more than 120 cases that have been reported, of which 50 GBS patients have been positive for a Zika virus in one test or another. And we've identified 10 other patients with other neurologic conditions that have also been positive for Zika virus. And most of these cases are encephalitis cases. So looking at this, how these patients presented by week of neurologic onset, we don't really see that big of a pattern necessarily. We do start seeing that around week 23, we have at least one case of Guillain-Barre that has evidence of Zika virus infection every single week, right? So I think that that's kind of novel. And if we look at how these other neurologic conditions are distributing over time, we also start to see that around week 27, we have one case or so every single week. So just to give you in perspective, week 23 is the beginning of June, and week 27 is about the beginning of July. If we overlay that with the number of Zika virus infections that have been confirmed by laboratory tests, we see that just at that same time that we're seeing the increase of Zika virus in May and into June, July, and over the summer rainy months, we have this conglomeration of patients that are presenting every single week. And just yesterday, we reported as the Department of Health over 22,000 confirmed cases of Zika virus. And we expect that these are just a very small proportion of the actual number of Zika virus infections on the island. Sometimes I think it's good to change perspectives a little bit. So let's start with the patients with GBS that don't have evidence of Zika virus infection, right? We're not asking people to just report those that they suspect had Zika virus infection previously, but anybody who has GBS. So as we expect, we see about 5 cases per month reported to the surveillance system. And we're still collecting data on what these might be due to, but what it tells us at least is that we're identifying most of the Guillain-Barre patients that are presenting on the island. As we anticipated, we'll have about 5 each month. Now, if we look at just the ones that have evidence of Zika virus infection, we can see that there's a trend, an increasing trend starting in April, exactly that same time where we start to see the increased number of Zika virus infections. And in August, we've reached 14 GBS patients with confirmed Zika virus infection. So putting it all together with patients that still have pending results for Zika virus, these 5 patients, we see a very strong increase throughout the summer months. And I can tell you that in September, we've also had quite a few cases of Guillain-Barre that have been reported to the Department of Health. Looking by age and sex, we see that as expected, the majority of our patients are over the age of 50 with a median age of 55, ranging from 21 years old to 88 years old. Slightly unexpected, however, we have 27 out of our 50 cases with evidence of Zika virus infection are females. Usually, epidemiologically, we see that more males are affected by Guillain-Barre than females, but we're doing investigations to try to figure out why this is. This is the map of Puerto Rico by public health region. We see that the great majority of our cases are residents of the San Juan metropolitan area. Here, 25, that is 50% of our patients, followed by the area that's directly next to it, Bayamon. And this was really followed the epidemic of Zika virus. So as soon as we started seeing this uptick of Zika virus in Bayamon region, we also saw increased numbers of GBS patients presenting at hospitals in this area. But it's important to note that almost all the island is covered by having having residents who developed GBS after infection with Zika virus. So just to conclude and wrap up briefly, for public health, we have several key objectives. The first is to identify suspected cases of GBS as soon as possible. This allows us to give a better diagnostic of the antecedent infection, especially with Zika virus, and also to provide better provider support. Additionally, other health providers can report other neurologic conditions to the system. We do a lot of support for our healthcare providers towards improving patient diagnosis and treatment. I think in this year, I've given 60 talks alone. We found that actually going to the ERs, going to the hospitals, meeting with people, not letting them just read an email about why we were concerned, but actually sitting down face-to-face and showing some of the data so that they could also be concerned has helped out a lot. As I mentioned, we provide laboratory support for the diagnosis of these preceding infections with Zika, chikungunya, and dengue virus, and we'll be adding Campylobacter in the next month or so. And this is really going to help us better understand this association between Zika virus and Guillain-Barre. And finally, now that we're seeing many of our patients leave the hospital and re-enter their communities, many of these patients are not very well off. It's the same people that we see that can't afford screens, that don't have air conditioning, that have these pools of water that they can't get rid of in their communities, that go on to be exposed to Zika virus, that go on to develop GBS. So we're really indebted for the support of the Guillain-Barre CIDP Foundation. I'm indebted personally to your openness with me to tell me about your experiences. I'm incredibly grateful, and I look forward to taking back this information to Puerto Rico so that we can also support our patients as much as possible on the island. So with that, I thank you very much.
So thank you, Emilio. I think we're going to move on with our programming, but Emilio is here for the rest of today, and I know would welcome your questions during coffee breaks and meals and that kind of thing. So thank you so much for being here, Emilio.